Assalamu alaikum. Uh, how are you students? I hope all of you are doing well. So bache, first let's discuss the assignment that I gave you. So many students have sent me the assignment already, and I'm very happy that you're doing an effort to read the questions, understand what is being asked in the question, and then answering the assignment. And most of the students I've seen the assignments of assignments are very neat, nicely done, and each thing is up to the mark. Now let's discuss the questions, what I was trying to ask and what was the answer. So regarding the thyroid hormone, the first question was if the level of thyroid stimulating hormone is increased and level of T3 and T4 are decreased, what condition would it signify? So as you know, T3 and T4 are the main hormones that are produced by the thyroid gland. So decrease in the secretion of T3 and T4 signifies hypothyroidism. It is understood, well understood. Now most of the students have answered this question correctly, that it is hypothyroidism. But the thing that I'd be more interested in is who got the point of the question. That was, there are different types of hypothyroidism. What type is it? So as we can see, the general signals for the thyroid stimulation would be from the anterior pituitary, that is via TSH secretion. If the TSH level is increased, it means the pituitary is working correctly. So if the pituitary is fine, it means hypothalamus is fine, TRH hormone is being released. So where does the problem lie? The problem lies in the thyroid gland. Pituitary is doing its work. It is releasing the TSH, thyroid stimulating hormone. So it is primary hypothyroidism, primary type of hypothyroidism, because the problem is in the primary organ that produces the thyroid, that is the thyroid gland. So the problem is in the thyroid gland. It is not being stimulated by the thyroid stimulating hormone. That is why the problem lies there. So the answer to this was hypothyroidism. That's correct. But if you wrote primary hypothyroidism would be the best answer, and it would fetch the maximum marks. Now if the level of TSH, T3 and T4 all are decreased, then what does it signify? Now let's look at this question in the same context in which we've looked at the previous question. So here the T3 and T4 is lowered. It means there is hypothyroidism. It is understood. Now the level of TSH is also decreased. It means there is problem in the pituitary gland or the hypothalamus. So this is secondary hypothyroidism due to problem in the pituitary gland or the hypothalamus. So the answer to this one was secondary hypothyroidism. Now if the TSH is decreased and T3 and T4 is increased, what does it signify? T3 and T4 is increased, it means there is hyperthyroidism. And if the TSH is decreased, it means the negative feedback mechanism is working fine. Negative feedback is being given to the pituitary gland and it is not producing TSH anymore. So where does the problem lie? The problem lies in the thyroid gland. So this is primary hyperthyroidism. If there was increased TSH as well as increased T3 and T4, then it would be secondary hypothyroidism because TSH is increased. And if the hypothalamic hormone, that is TRH, that is also increased, then it would be tertiary hypothyroidism. Okay, so this is how we answer these questions. Now the fourth question was deficiency of iodine causes goiter. How does it cause goiter? How and why? So for that, first we need to understand what is goiter. Goiter is a condition in which the thyroid gland grows to huge proportions. Why? Because of overstimulation of the follicles, over uh, you can say production of the follicular cells. Now what happens is that in hypothyroidism, primary hypothyroidism, the thyroid hormones are not being secreted, T3 and T4 are not being secreted, the level is decreased. So it gives feedback to the pituitary to increase its secretion so that the T3 and T4 could be produced. So TSH secretion would increase, which would in turn act on the cells in the thyroid gland and proliferate the cells. There would be hypertrophy of the cells, that is increased cell size, and hyperplasia of the cells, that is increased number of cells in the thyroid gland, and as a result the thyroid would grow to huge proportions. Now why does this occur? Why the hypothyroidism occurs in absence of iodine? Because iodine is a major constituent of the thyroid hormones. So thyroid hormone is known as, T3 is triiodothyronin, T4 is tetraiodothyronin. So iodine is a component of the thyroid hormones. If the iodine is not being taken in via food, or it is insufficient, it would cause less production of the thyroid hormone, even if the thyroid is fine, even if the thyroid is working correctly. If we do not give it the materials which it needs to produce the T3 T4, then T3 T4 won't be produced anymore, or it would be released in decreased amounts. This would cause TSH stimulation, increase TSH level, and this cycle continues. That is why the size of the thyroid is increased, and that is known as goiter. So this was your assignment, and if you answered all the questions correctly, I congratulate you, and if some of the answers were not up to the mark, there's no issue. Okay, at this level you should at least differentiate between, you should know how to differentiate between hypothyroidism and hyperthyroidism by looking at the picture, by looking at the lab reports. Now if it is primary or secondary, that comes next. Okay, so if you answered these correctly, the first was hypothyroidism, second hypothyroidism, third hyperthyroidism, it's okay. And if you answered it like this, primary hypothyroidism, secondary hypothyroidism, and primary hyperthyroidism, then it is even more good. So thank you for the feedback, and I look forward to seeing that diagram of renin, angiotensin, aldosterone system from you. A few students have already sent me the assignment, and I hope that all of you would submit it by Monday. So best of luck with that. So now we're going to continue our main topic, that was the adrenal gland that we were studying in the previous lectures. So let's continue on with the adrenal gland. So we've studied about the hormones which are secreted, their regulation. Now we're going to look at the applied physiology of the adrenal cortex. That is what diseases can be seen in the adrenal cortex. So let's start that. So if there is hyperactivity of the adrenal cortex, that is, adrenal cortex is over vigilant, it is over secreting the hormones, or secreting the hormones in increased quantities, there can be different diseases which may be attributed to this. The first one is primary hyperaldosteronism or Conn's disease, in which the pituitary and the hypothalamus are not to be blamed. They are normal, but the aldosterone is being released in larger quantities from the adrenal gland. This disease is also known as Conn's disease. Then there is Cushing syndrome, in which cortisol is being released in larger quantities. And then there is adrenogenital syndrome, in which androgens are released in larger quantities. If there is hypoactivity of the adrenal cortex, that is, the hormones are being secreted in less quantities than normal, it can be Addisonian crisis or Addison's disease. In acute adrenal insufficiency, that is, the adrenal gland was just working fine a few days back, and then suddenly it just stops working, as in some viral infections or due to effect of some drugs. This condition is known as Addisonian crisis, and this can prove fatal. And if there is chronic adrenal deficiency, it is known as Addison's disease. So Addisonian crisis is also known as Addison syndrome, and Addison disease is when there is long-term insufficiency of the adrenal gland. Now let's study about these diseases one by one. The first one that we're going to review now is the primary hyperaldosteronism or the Conn's disease. So primary aldosteronism, which is also known as primary hyperaldosteronism, is characterized by overproduction of aldosterone by the zona glomerulosa of the adrenal cortex. This would cause adrenal hyperplasia, that is, increased number of cells of zona glomerulosa in the adrenal gland, and the other cause can be aldosterone secreting adenoma, that is a benign tumor of the adrenal gland. So either the cells are normal but are in larger number, that is the adrenal hyperplasia, or the cells are in normal number or are larger in number, but there is a benign tumor that produces aldosterone uncontrollably. That would also cause primary hyperaldosteronism or Conn's disease. So this disease is due to an adenoma or hyperplasia of the zona glomerulosa. What effects would it have on the body? So all the effects of aldosterone would be produced, but on a larger scale, on a severe scale. So excess aldosterone, if released, would cause increased reabsorption of sodium chloride from the renal tubules, and where the sodium goes, water goes. So increased sodium and water retention in the body, which would cause hypertension or increased blood pressure, as well as tissue edema, that is increased extracellular fluid, increased interstitial fluid accumulation within different tissues. Moreover, there is increased excretion of potassium and hydrogen ion, which would cause hypokalemia, that is decreased concentration of potassium in the blood. This could prove to be fatal. This could cause cardiac arrhythmias, cardiac irregularities. Our heart has a specific rhythm by which it beats. So if you listen to the heart of a person by stethoscope, it has two beats, lub dub, lub dub, lub dub. That is the cardiac cycle, in which first the auricles or atria would contract, ventricles would relax, the blood would be pumped into the ventricles, then the ventricles would contract, atria would relax, and the blood would be pumped out from the heart. So this cycle should work precisely like this. If there is miscommunication between these two parts, if the ventricles and atria are contracting at the same time, there is no more blood that is being pumped out into the body. This dissociation of rhythm between the atria and the ventricles is known as cardiac arrhythmia, and this can be caused due to deficiency of deficiency of potassium in the blood. Moreover, if there is more excretion of the hydrogen ion is the ion that maintains pH of our body. There would be increased bicarbonate ions in the body, which would cause alkalosis. This type of alkalosis is known as metabolic alkalosis. Metabolic alkalosis may cause tetany, may cause very serious consequences in the body. If the pH is not being maintained, alkalosis would have severe effects, as it would decrease the breathing rate, respiratory rate, to conserve more carbon dioxide into the body. That would decrease the oxygen coming into the body as a compensatory mechanism. Respiratory acidosis would start to occur, the body organs would start to shut down, and this could prove fatal for the person. One of the diagnostic criteria for this primary hyperaldosteronism is a decreased plasma renin concentration. So what happens is, if aldosterone is being produced in huge amounts, the renin, that is the precursor for the aldosterone release, would start decreasing in the body, because the aldosterone is being produced without its effect. So renin would not be produced anymore. If the renin is not being produced, the patient may undergo may have severe consequences on our body. The feedback suppression of renin via excess secretion of aldosterone, or by the excess extracellular fluid volume and arterial pressure resulting from the aldosteronism, occurs. So this aldosterone being released in huge quantities would suppress the release of renin from the kidneys, and this would in turn this would also be exaggerated when there would be too much extracellular fluid accumulated in the body, which would cause edema, and this vicious cycle would go on, and the patient would face serious issues. The next disease that we're going to study is the Cushing syndrome. This hyperaldosteronism or Conn's disease was the problem in the zona glomerulosa with the aldosterone metabolism, but Cushing's syndrome is associated with the cortisol. So Cushing syndrome is an endocrine disorder which is caused by high levels of glucocorticoids, mainly cortisol in the blood. So there is hypercortisolism. So the effects of cortisol would be exaggerated. As we know, cortisol acts on the whole body, so we would have wide range of effects on the body. So there can be many causes to the Cushing syndrome, some of those endogenous and some of those exogenous. Endogenous causes are those causes which are inside the body, there is no external stimuli for them, whereas exogenous causes are due to external stimuli. So there can be pituitary Cushing's, that is, if there is a benign tumor of pituitary gland that is uncontrollably secreting adrenocorticotropic hormone, this adrenocorticotropic hormone would keep on stimulating the adrenal cortex to secrete cortisol. This is also known as Cushing's disease. So if the cause is pituitary adenoma, this would be known as Cushing's disease. Remember this point. There can be adrenal Cushing, that is, excess cortisol is being produced by the adrenal gland tumor or the hyperplastic adrenal gland. Adrenal gland tumors, most common, are known as pheochromocytomas. So due to pheochromocytoma or hyperplasia of the adrenal gland, too much number of cells in the adrenal zona fasciculata, it would end up in releasing too much cortisol. They could be ectopic or paraneoplastic Cushing syndrome, as in small lung cancer. In small lung cancer, the cells in the lung, they differentiate in such a way that they start mimicking the action of the zona fasciculata, and they start releasing cortisol. So there is ectopic release or paraneoplastic release. Ectopic means whenever an epithelium or a set of glands is present on a site other than their original site, this is ectopic. For example, in ectopic pregnancy, the embryo implants on a site other than uterus. For example, if it implants within the fallopian tube or within the ovary or within the pouch of Douglas or within the intestines, this would be known as ectopic pregnancy, because this tissue should not be present there. It should be present in the uterus, but it is present at some other site which is not normal. Paraneoplastic is whenever there is a tumor involved and that is doing the work of some other gland, etc. So paraneoplastic term relates with the tumor, whereas ectopic relates with presence of the normal tissue at some unusual site or abnormal site. There could be exogenous causes. Exogenous causes are the causes which are due to external stimuli. The most common cause of Cushing syndrome is exogenous administration of glucocorticoids or iatrogenic Cushing syndrome. So we take dexamethasone for small problems as prescribed by a quack or a doctor. If we keep on taking steroids for a long period of time, dexamethasone for a long period of time, it would cause Cushing-like features or Cushingoid features. So this would be known as iatrogenic because it is due to treatment, due to taking outside medicine. So iatrogenic Cushing syndrome it would be known as. What are the features of the Cushing syndrome? So all the effects of the cortisol, but at a much larger level. These effects would be enhanced. So it breaks down lipids, proteins, glycogen, makes more glucose available. So what would happen is, due to breakdown of lipids, due to breakdown of fat in the body, there would be disproportionate distribution of fat in the body. There would be too much submental fat. So and the face would feel like a round moon-like face. That is known as Cushingoid face or moon face or edematous face. Moreover, fat gets accumulated on the upper back, on the back side of the neck, which is known as buffalo hump. It is just like a hump, just a camel's protein, a hump, or on the buffaloes. It looks like that, as you can see in this picture. So fat deposition in the upper back is also a feature of the Cushing syndrome, and it is known as buffalo hump. There would be pot belly. Pot belly is when there is excessive accumulation of fat in the abdominal area. So accumulation of fat in the upper abdomen would cause pot belly. As you can see here, this patient has pot belly. Moreover, there would be purple stria. Because of excessive accumulation of fat, there would be stretching of the skin. We would see reddish purple stripes on the abdomen as seen on the abdomen of a pregnant female. That is physiological, that is normal. But if it is seen in a patient who is not pregnant, due to excessive distribution of fat, due to increased cortisol, it is a problem. So it is due to stretching of the abdomen wall by excess subcutaneous fat and depletion of subcutaneous collagen fibers. So this is these are the purple stria which are seen in the abdominal region. Moreover, the patient would appear as if the typical appearance is known as lemon on a stick. So if we stick 2 toothpicks into a lemon, how would it look? It would look like a large round shape on the upper side, and then small thin lean sticks on the lower side. So the limbs of the person, arms and legs, they would be very thin, just like lemon on a stick appearance, whereas the abdominal part, the face, would be swollen just like a lemon. Moreover, in the face we would see redness, excessive redness. That would be known as plethora, because one of the functions of the cortisol is increasing the production of red blood cells. So there would be increased red blood cells, and there would be facial plethora. Moreover, there would be hirsutism. Hirsutism is excessive growth of hair on the body. Zona fasciculata to some extent also secretes some androgens. So that's why there would be excessive growth of hair on the chest, on the face, on the neck, etc. Cushing syndrome would also cause hypertension. Now remember one point: all of the endocrinal disorders, they would cause hypertension except Addison's disease. In Addison's disease there is hypotension. All of the others would cause hypertension, increased blood pressure. So there would be hypertension due to mineralocorticoid activity of the glucocorticoids. As we know, glucocorticoids have mineralocorticoid aldosterone-like activity to some extent. So there would be increased reabsorption of sodium and water, which would cause hypertension or increased blood pressure. If we look at the musculoskeletal system, there would be increased protein catabolism, that is increased breakdown of protein and fat from muscles. That is why we would find muscular weakness in the patient of Cushing's. Moreover, there would be osteoporosis and pathological fractures. The bones would get too much thin, and pathological fractures would be common. I've already explained what are pathological fractures. There is no history of fall, there is no history of trauma. The patient was just sitting, and when he stands up, he has a fracture in his femur. That is a pathological fracture. And there would be thin, lean extremities due to loss of muscle mass, due to loss of muscle fat. There would be hyperglycemia due to gluconeogenesis and glycogenolysis. So as cortisol keeps on producing more and more glucose in the liver, this would cause increased blood sugar level, blood glucose level. There would be immunosuppression. One of the functions of the cortisol was to suppress the immune system. And if cortisol is being released in large quantities, immune system is suppressed too much, and this would weaken the immunity of the patient and make him or her susceptible to increased risk of infections and delayed wound healing, as it also prevents the chemotaxis of white blood cells, etc. There would be pigmentation. As I told you earlier, if there is increased adrenocorticotrophic hormone, the precursor to adrenocorticotrophic hormone is pro-opiomelanocortin. One of its components is MSH, melanopart. Melanopart translates to the melanin stimulating hormone. Due to this melanin stimulating hormone, the melanocytes on the skin would get overactivated. They would start producing melanin that darkens the skin. So there would be skin pigmentation, too many moles, darker skin. Skin would get thin and easy bruisability can be seen due to protein catabolism. So as the proteins in the skin, they would get destroyed, skin layers would get thin, and patient, even if he bumps into a wall slightly or into a table, would develop bruises over the skin, color changes over the skin. So this is how a patient of Cushing syndrome would look like. There would be euphoria. The patient would feel good all the time. No more doom or gloom. He would not be worried by anything. So because it elevates mood, cortisol elevates mood. But sometimes depression or psychotic symptoms or emotional liability may develop. There are always exceptions. So depression may develop, but most of the time the patient would feel euphoric, as if he's flying in the air. He's at too much peace with himself. There would be buffalo hump, as I've told you earlier, hypertension, increased blood pressure, thinning of skin, thin arms and legs, muscle wasting. There can be benign intracranial hypertension due to increased accumulation of fluid in the body. Fluid also starts increasing in the brain, and there could be benign intracranial hypertension. Cataracts, if there is too much glucose in the blood, it starts depositing in the lens of the eye and it would cause blurring or cataracts. There would be moon face, round, large face with red plethoric cheeks due to overproduction of RBCs. There would be increased abdominal fat. There would be stretching of the skin. There would be avascular necrosis of the femoral head. As the blood gets thicker and thicker, the femoral head is a very sensitive point where there are small capillaries which is supplying this part of the body, and it is very prone to ischemia. So if a capillary gets blocked due to atherosclerosis or increased blood glucose level, avascular necrosis of femoral head may occur. That is, the blood supply would be compromised and the cells there would start dying. Easy bruisability can be seen due to thinning of skin, and poor wound healing can also be seen. Also, other things that are observed here would be osteoporosis, that is thinning of bones, formation of holes in the bones. Osteoporosis literally means this, but there would be decreased calcium content, thinning of bones, easy fractures, pathological fractures. There would be tendency to hyperglycemia, so blood glucose level would be increased. There would be negative nitrogen balance due to more alkaline environment in the body. There would be increased appetite. The patient would always feel hungry, keep on eating. There would be increased susceptibility to infection due to decreased immune functions, and there would be obesity. Patient would get more fatter. So again, cortisol excess would cause diminished protein synthesis. Moreover, breaking down of proteins, which would cause muscle wasting and weakness. It would also cause abnormal fat deposition, which would cause striae in the body due to stretching of skin. It would cause depression of immune reactions, which would cause tendency to bacterial infections. And gluconeogenesis occurs in the liver, formation of new glucose, which would cause hyperglycemia, increased blood glucose level, and glycosuria, that is increased glucose in the urine, sweet urine. Suppression of growth hormone would occur because cortisol is one of the stress hormones. So if there is increased cortisol being released, growth hormone would get suppressed. Moreover, growth hormone is being produced by pituitary. If pituitary is using all its energy to release the TSH, it would have no more power to produce the other hormones. So there will be panhypopituitarism that can be seen too. So arrest of growth in children due to decreased growth hormone. Moreover, there would be osteoporosis, which would cause kyphosis. Kyphosis is bending of long bones. So the bones of the leg, the bones of the arm, they would start bending. There would be hypertension, that is increased blood pressure, and degree of virilism is common in women. The woman would start showing men-like features and would get sterile. They would not be able to produce more children. So this is how a Cushingoid face looks like. Moon face, extra deposition of fat, and there is redness of the cheeks, as we can appreciate the redness. Then there is excessive pigmentation, as we can see the melanin, darker hue of the skin. And after giving treatment for this, there are some hormones that could block the cortisol. After giving those or after surgery of the pheochromocytoma, the patient looks like this, starts getting normal. So this was our Cushing's disease. Now the adrenogenital syndrome will inshallah study in the next lecture, when we'll be inshallah finishing the adrenal gland, then we'll start the pancreas. So please submit the renin-angiotensin aldosterone system that I've given you in a day or two. See you guys on Monday inshallah. Take care. Allah Hafiz.